for the first case series, the master class series of ASAMI India of this session. Currently in the world, everything is in hybrid mode, including teaching and learning. So following the same protocol, we are having this webinar on master series other than the physical workshops. So without wasting time, I invite my all faculty speakers to share with these presentations and enlighten all of us. So I hand over to Shamsul to have a brief about them, about the CV, and then we can start the presentation. Shamsul, please start.
Thank you, sir. Thanks a lot, sir. So, very good evening to all. I welcome you all into this first webinar of this session. This is a pure academic and interactive session, so all delegates can come on Zoom and discuss and ask the question directly from the faculty. So, today we have the first series of Meet the Masters webinar due to this Bihar chapter. Our first speaker is Professor Novikov, Constantine Isaac. He is a leading research doctor, traumatologist, orthopedic surgeon of the highest category, Russian Ilizarov Scientific Center, Restorative Traumatology and Orthopaedics. Title of MD is surgical lengthening of extremities in patients with low subjective and low growth by the method of control, transverse osteosynthesis. Author of over 190 scientific publications and over 45 inventions and utility models, more than 120 efficiency proposals. He is a speaker at major scientific conferences in Russia and other countries like Armenia, Bangladesh, Egypt, Canada, China, Czech Republic, India, Israel, Italy, Iran, France, Germany, Mexico, Senegal, Serbia, South Korea, Spain, Switzerland, Pakistan, Poland, Uzbekistan. So let's invite Professor Novikov from KURGAN, Russia, for his talk.
Dear friends,
Novikov, sir.
Dear friends, let me say thank you very much for Dr. Hoda and for President of ASAMI India, Professor Rajat. I want to congratulate all of you, Hoda, with your today position Secretary ASAMI of India. And Rajat Agrawal, you my friend, and I congratulate you with this is high level. You are president and biggest country in the world, and I'm happy because your country just now and in the past so many years use our Russian methods of Ilizarov. And let me today explain about my feeling. What is it Ilizarov methods for me? This is not only frame, this is not only metal, and this is a little bit more. Did you see me?
Yes, sir. Please, sir.
And all body know Ilizarov. This is orthopedic Soviet surgeon, inventor, doctor of medical science, professor, academician, and etc. But for me, he is teacher. For all of doctor in the world, this is apparatus. Somebody knows this is methods. Few doctor know this is effect. And when we start talk about what is it, Ilizarov methods, for me, this is life. From simple doctor, this great man go to the future with excellent theory and excellent methods of treatment. He start from a small village in the Russia, like simple doctor, and he first who understand how start regenerate our body, not only bone. And all of picture with Ilizarov. Just now you can see here operation team, but eyes of Ilizarov inside of this picture. He try read what this picture show. He first from surgeon in the world who understand what this picture show. And again, during the surgery, he check picture on X-ray. And this is Professor Ilizarov. This is apparatus of Ilizarov. And with this frame, with methods of Ilizarov, he can get effect of Ilizarov. And when we, like doctors, start understand which kind of difference between apparatus and effect, we will change our mind. More than 40 years, I use only one method in my life, methods of Ilizarov. And only now I start understand something magic, what I can do with simple metal. And you see, this is patient Ilizarov, all time contact with patient, because after surgery, apparatus cannot get result without doctor and without patient. And doctor who will start treat with Ilizarov apparatus need understand. He will spend all time, all life for patient, and this doctor cannot go away from patient, because without knowledge of Ilizarov, and without knowledge of us, Ilizarov apparatus cannot create a miracle result, effect of Ilizarov. Again, you can see here picture, here face of doctor. He is not only doctor, he is scientific. And doctor, please remember, our future in the hand of patients. If you know who is it, this is Olympic winner Valery Brumin. He got a gold medal in Olympic Games in the Roma, and he has accident. He has fracture of tibia, pseudarthrosis, so many surgeries, and Ilizarov, like simple doctor, support. This is great man, and after that, all of the world know about Ilizarov. Ilizarov, author of more than 200 inventions protected by copyright certificate of the Soviet Union, and all of the life he continued create something new. And he was little bit, I cannot say crazy, but very strange. And he worked with the same doctor who want create something new. We have a special department, still we have special department when any doctor can create some details for Ilizarov frame. He is teacher. So many doctors from all of the world get from him and can say, Ilizarov is my teacher. For me, he is not only teacher, he is my father. More than 9 years, near 10 years, I work shoulder to shoulder with him. And any patient has all of picture from beginning till end of the treatment. And anytime when patient has a consultation with Ilizarov, Ilizarov start check all of X-ray of this patient for understanding all process from beginning till finished. Here, so many doctors from all of our institute, you can see so many X-ray pictures. Ilizarov asked not last X-ray. He, with understanding of last X-ray, he immediately asked about what was 10 days ago, what was 1 month ago. And we start understand too what Ilizarov says. It's me 40 years ago. And this is doctor from Iraq, maybe 35 years ago. This is patient from Italy. And any X-ray show which kind of manipulation we need to do for this patient. It's me with Ilizarov during the surgery. And again, X-ray, X-ray, X-ray. Without picture, we cannot to do next step. And doctor, please, any manipulation, ask opinions, what see your radiologist. If you will contact with radiologist, your result will more better than we will see this X-ray alone. Ilizarov, this is apparatus. Original apparatus from Epoca de Ilizarov. This is old frame. Just now we have so many new details, and I want to say thank you very much, because Indian device just now I think better than Russian, with high quality, with new details, and generally Asian patient buy and use apparatus from India. And this is original device 35, 40 years ago. Doesn't matter which kind of apparatus, from metal, original, Chinese or Argentina, Indian or Russian, from bamboo or from plastic, this apparatus generally with Ilizarov methods, we can get and we can create Ilizarov effect if you know rule of our methods. All of this picture I took from internet, and sometimes like here we can see original Ilizarov frame, but sometimes this is not Ilizarov methods because patient have some deformity, patient not use extremities, patient not follow instructions doctor, and not to do exercise. But usually like here, after surgery, our patient walk and take weight bearing, and again doctor check not only position of apparatus. Ilizarov check any step inside of radiography. Here, with another external fixator like TSF, we can get Ilizarov effect. But my patient prefer original. I recommend this is excellent variant for correct deformity. But new patient ask old patient what is better, old system Ilizarov frame or new system with GEX support. At my patient prefer old apparatus. And when we talk about Ilizarov effect, we need to understand what is it. And doctor, only imagine when we press or when we distract, our body start answer with growing. And just now I can say Ilizarov effect, this is general biological property of tissue to respond to meteorite stretching or compression by growing and regeneration. And when we talk about body, this is not enough, because Ilizarov effect, this is genesis, all tissue genesis, skin genesis, myogenesis, neurogenesis, osteogenesis, all of tissue with simple Ilizarov device start grow if you know rule. This is the magic of Ilizarov, not only frame. Like now, you see doctor touch metal and body answer with magic effect. And like alphabet, A, B, C, D, E, and you need know how must to do all of steps. And everything is important. Position in operation theater. How patients start walk and use operated limb. And you can see Ilizarov show with this is very busy man, but he go to the gym and show for patient how must take weight bearing. Only imagine you show your patient how must use operated limb. This is women still work in our institute. More than 50 years ago, she all time worked with Ilizarov, and just now she more than 70 years and continued her perfect job. This is picture near 40 years ago. This is all of my patients with achondroplasia, with pseudoachondroplasia, with cosmetic lengthening. And all of these patients has more than 10 centimeters lengthening. In Epoca-Day Ilizarov, we have haven't limit for lengthening. Just now we think about centimeters, not about centimeters. We think about results, about regeneration. And only imagine 14 centimeters, 14, here more than 10, here more than 10. And all of patient walk without any support, only imagine. And you can see position on the foot. And with this picture, I want to show what is it rehabilitation during our treatment. Without gym, without activities, we cannot get result. And this is two methods of Ilizarov, because without activities, we cannot create perfect body. This is our Epoca, still more than near the 10 centimeters, more than 10 centimeters, correction deformity, and all of patient any day, include of weekend, go to the gym for exercise. Baby is baby. And again, Ilizarov, sorry. Very sorry. And I want to invite you, all of you, in our center, because here, not from lecture, with your skin, you will understand what is it Ilizarov effect. And Ilizarov was general director. Only imagine 12 orthopedic center in the Soviet Union. This is a maquette of our institute. Ilizarov, this is politic. Ilizarov, this is orthopedic, very famous orthopedic center in the world. This is biggest orthopedics clinic in Russia. And 40 years I work here. Ilizarov, this is ASAMI, International Association of Orthopedic Surgeon. Ilizarov, this is conference, international conference, not only in the Russia. This conference, Ilizarov readings, which will any June, and I invite you for this is conference this year. So many doctors from all of the world usually come in our center. Ilizarov, this is monument. In front of our center, you can see, you can talk with our father. And each birthday, 15th of June, all of patients, all of doctors from our center go for the monument, put on so many flowers. Ilizarov, this is Memorial Park. We have monument for animals. We have museum. We have monument for car of Ilizarov. We have alley. And Ilizarov monuments we have not only in Kurgan. This is city of Gusar in Azerbaijan, city of father of Ilizarov. This is 6 meters height monument for apparatus. Just now, pretty perfect monument in Italy. Parents of Carla Mauri. Carla Mauri, this is very famous traveler in the world, patient of Ilizarov, and parents of Mauri open this. Next time I will show this is monument in Italy. Museum, old office of Ilizarov. Just now this is museum, chair of Ilizarov, and I was 40 years ago and show my patient here. We have, I think, perfect, good museum, and all of exponent with Ilizarov device. Here, patient from Serbia, from Hungary, from Russia, from Ukraine. And all of details we collect, select in this museum, and here metal which remember warm of hand of Ilizarov. All of this apparatus from Ilizarov epoch. First Ilizarov device must go there. Ilizarov, this is magazine, very good, very famous magazine. And if you have some material, I invite you for published in our journal, Genius of Orthopedics. And Ilizarov, this is planet in the sky. And just now, if you look to the sky, you can see this is planet. Our airport in Kurgan has name of Ilizarov. When you will come, you can see and read airport by Ilizarov. In our city, we have road by Ilizarov. And when you will ask taxi driver, please show me Ilizarov street, they will show you. He is laureate of USSR State Prize, honorary doctor of the Russian Federation, honorary inventor of the Russian Federation, honorary inventor of Soviet Union. And you can see, I cannot say this is doctor. This is legend. And for us, here, I want to finish. This is not simple tree. Any tree, this is our colleagues who already died, but any tree has name. And here, inside of big arch of Ilizarov, we write down name of this doctor. And we have alley, so many trees already we have. And I want to back to the next life, like tree near the Might Center. Carlo Mauri says, Ilizarov, this is Michelangelo of orthopedic. Here Michelangelo and his monument of David and another genius and his monument of Ilizarov apparatus. This place where our teacher died, each time when he has birthday, we go and get something from this place. Dr. Ashok, Dr. Barry, and so many other doctors, anytime when they come to Russia, to our center, they go and stayed near this tomb. This delegate from Bangladesh, Ilizarov, this is communications, and this is not only communications like now, because any communications change our life. You can see doctors from all of the world come, see, and cannot believe what's happened inside of this metal. This is 5 years ago in Bangladesh, in Iran. And there, doctor has a very big interest for our methods. I think everywhere, when doctors start to understand what we can do with metal inside of our body. This is surgery was in Bangalore, in India, 5 or 6 years ago. And anytime doctor says, this is impossible, Ilizarov can answer, this is possible. And Ilizarov give us possibilities without control of time, connect with so many doctors from all over the world. Dr. Salomin, Professor Shevtsov, Dr. Bari, me, Dr. Arshat, Dr. Artemiev from Russia, he from Moscow. And all life he spent for Ilizarov methods. Little bit strange, but with Ilizarov methods, he support so many doctors from all over the world. Dr. Peli, Shevtsov, Ilizarov. This from Tehran, Dr. Kirienko. And all time we talk about patient. All time we talk about magic of Ilizarov. Ilizarov, this is how I can say. This is what from Ilizarov. And Ilizarov says, Ilizarov, this is minimally invasive surgical intervention. And Ilizarov says, bloodless surgery. And Ilizarov, this is rigid fixation of bone fragment. Ilizarov, this is possibility of early loading on the operated limb. Ilizarov, this is possibility of the function of adjacent joint of the operated limb. And very, very, very important, Ilizarov, the ability to control bone fragments from the moment of surgery to time when we remove device. This of magic Ilizarov. And for surgeon, Ilizarov, this is an opportunity to solve any most difficult orthopedic problem. This is true. And for patient, Ilizarov is an opportunity to get a result when another methods of treatment are powerless. And Ilizarov, this is philosophy, and all time I show this is excellent word from heart of surgeon. This is surgeon from Iran. More than 10 years ago, he was with short visit in our center, and this is 1 week change his life. For me, this is Ilizarov forever. I cannot imagine my life without result. And any week, not each day, but all time, all my practice, I correct in other methods of treatment, including today. I have one woman after a car accident. She has so many surgeries. Still, she has a nail in her femur. She has shortening deformity, and many years she still haven't good result. And I hope next month we will support with Ilizarov magic surgery. This is our father, our teacher, our magic colleagues. Thank you very much for your attention. And Ilizarov, this is not only metal. Ilizarov, for me, life. Ilizarov, I won't repeat again, this is possibilities for us. This is wings under our shoulder. Thank you again. And I want to invite you in our center where you can see so many different departments and different results. Rajat, I hope our collaboration will support for our patient. Thank you for your time.
Thank you, sir. Thank you, Professor Novikov. Thank you for this very beautiful pictorial presentation, for giving us an insight from where we all started. Everybody knows, especially the young surgeons, the current that there is an Ilizarov. But with this presentation, we came to know where it all originated. So it was very important to us, sir. I have a request, sir, that many of the young surgeons, they want to come for short-term fellowships in Russia. So can you please let people know what is the procedure and how can they come for the fellowship, short-term fellowship?
Dr. Rajat, смотри, you can contact through orthopractica.com. This is my private channel. There we can very quickly understand what patient want. Just now, administration give me possibilities, invite a special, for example, patient want to go to orthopedic. I can give a telephone number or international department or my, and very easy contact. And you're absolutely right for understanding what patient, what our doctor need. First time, I think enough, maybe 1 week, maybe 10 days. Then make plan for, I don't know how many. For example, Dr. Hoda know, Dr. Mirzamurodov from Uzbekistan. First time he come for 1 week. Then he come for 3 months. Then again, he come for 3 months and he understand what he want. And or here, orthopractica.com, or directly this telephone number, you can write down by WhatsApp, by Viber, or international department, Dr. Hoda will help. But I think this is very good idea because this is 1, this is 11, and when we collaborate and when we will mix your knowledge and Russian knowledge, this is will multiply our possibilities. You're absolutely right.
Yeah. Thank you,
I invite
sir.
all of young doctor. I invite and I try my best. I will help in operation theater.
Yeah. Thank you, sir. Because before COVID era, we have sent fellows for short-term fellowship from ASAMI, India. And on this platform, we all will request you to accept 2 fellows from ASAMI, India for short-term fellowships for your guidance and expertise, so they can learn a lot from you in future.
Because I want little bit continued, because theoretical program, I think in India more better in the Russia. I invite you to the operation theater to Russia. And with Indian knowledge, theoretical knowledge, you will get perfect practical knowledge.
Okay, sir. Thank you, sir. Thanks a lot. Now I hand over to Shamsul to carry with the next speaker.
Thank you, sir. Thank you, Novikov, sir, for such a legendary historical talk, sir. Now, without wasting time, since we have more talks, so I'll request our next faculty, Professor RA Agrawal, sir. Dr. RA Agrawal, sir, is Director, Agrawal Orthopedic Hospital and Research Institute, Jubilee Road, Gorakhpur, UP, India. He's past president of UPOA, he's past president ASAMI India, he's ex-secretary Indian Foot and Ankle Society, ex-editor general of Foot and Ankle Surgery India. Dr. RA Agrawal received National Award for the Welfare of People with Disabilities in 2000. He's the author of 2 books. Number 1 is The Management of Club Foot by Positive Technique, co-author Social Pandey sir, and second is The Management of Equinus Foot by Ilizarov Technique. It's the same author. He has also published a paper in JPO, Journal of Pediatric Orthopaedics, named Post-Traumatic Pediatric Virus Long-Term Follow-up of the osteotomy using Ilizarov method of compression, retraction, osteogenesis. So now I invite RA Agrawal sir for his talk. He has a talk of role of Ilizarov in orthopedics. RA sir. We'll be taking the questions once all the talks are finished. Yeah, please, sir.
Okay. Good evening to everybody. I'm going to present role of Ilizarov in orthopedics. That is most important because we are doing a lot of Ilizarov surgery, but the people don't know how miraculous is the Ilizarov technique. Just I'm enumerating some of the presentations, some of the cases with the Ilizarov. There are thousands and thousands cases, but I'm presenting some of the cases. Orthopedic specialties are the joint replacement, arthroscopy, spine, trauma, infection, pediatric orthopedics, and limb lengthening and reconstructive surgery. That is Ilizarov. We start our surgery, our demonstration with the downward, that is from the club foot. Club foot, neglected club foot has a lot of problems. Some do some open surgery, some do osteotomy. But I tell you, this is a young girl, 18 years old. She has got severe equinus deformity. Even the equinus is up to the 90 degree. So you will be surprised to know that only we have done the tendo-Achilles lengthening by V-plasty and plantar fasciotomy. Gradually, destruction was achieved there. So a simple frame was applied following the positive principles. And after that, gradually the stretching and stretching, the deformity was corrected. And you can see that after some year, this is a perfect plantigrade foot with all the deformities has been corrected without any fault. The deformity mainly were equinus, adduction, and the supination, all the deformities were corrected. This is a pre-operative and this is the final photograph of the girl. Fully corrected, there is not a single % deformities left there. Another case, the main Ilizarov surgeon which you usually get is the tibia. Compound fracture tibia, proximal fracture tibia, distal tibial fracture, and infected non-union and the bone defect and the congenital pseudoarthrosis of tibia. These are the common problems of the tibia. For example, this was a girl, she got the infection in her childhood. There was 7 centimeter bone loss. So no technique other than Ilizarov can correct this. Gradually, we have transported the fibula and gradually at the rate of 1 millimeter. And you can see the final picture. This picture was taken X-ray after 21 months. The deformity is fully corrected. Another case is the pseudoarthrosis tibia. It's a common problem. Lot of problems are there. Lot of orthopedic surgeons, they are not able to tackle things. But we will show you how the distraction osteogenesis producing the osteogenesis. You can see the scar there. 2 surgeries were performed earlier, but it failed. So gradually what we have done the distraction. When we were doing the distraction, we came to see the first of all, we have corrected the angle here. And after that, you can see that the very bony, good amount of callus is formed due to distraction osteogenesis. And you can see the bone is united nicely. Good amount of callus was formed there. This is a preoperative and this is the final picture. Another case, now CPT is a common problem. So we are going to tell you that technique that we can say that 100% union can be achieved by CPT. It's a miracle technique and we assure you, if you follow this technique, you will get the 100% union. It's a very difficult to say 100%. But we are seeing we have operated many cases and we find that the bone united 100%. So what we have done initially, we have corrected the angulation by distraction, hinges and motor rods. And after that, this is a side, this is a cross union. Means the pseudoarthrosis side of tibia was exposed and surrounding periosteal strip being done, osteomatized, the periosteal of fibula was stripped. We have osteomatized the fibula also. The soft tissue between the tibia are removed, taking care of the tibialis anterior artery. The bone graft is taken from the iliac bone and put surrounding the tibia and fibula. You can see that we have put the bone graft here. So because we have studied the microscopic study of the tibia contains a fibroblast and osteoclast in pseudoarthrosis tibia. So when there is no osteoblast, the bone can't unite. So we thought to another technique, we apply a bone graft from the fibula. And after that, you can see that the good amount of tibia can't produce the osteogenesis. So we thought, why not from the fibula? So we have put the graft here, lot of graft put there, taken from the iliac case. Bone was aligned. You can see here. As soon as in 3 months, you can see that very good amount of the callus was cross union, but then fibula produces the osteoblast, which is surrounding the tibia. And after that, what happened? A good amount of cross union was there. We have, so you can see that this is the 6 months after removal of the frame, bone is united. And 15 months after the removal of the bone, here the bone has been very good amount of as a cross union is there. So very, very solid cross union is there. So there is no chances of the refracture. We have done the CT scan study here. It was a CT scan. You can see that very good tibia and fibula. This is the fibula, this is tibia. They have made a consistent like bridge. They have covered the bridge and this is the tibia. Those they have surrounded the tibia, and a good amount of callus is formed. The strong callus is formed there. We have done the 3D CT scan studies. You can see there how beautifully. So we can say in all the cases which we have operated, we have got the very good strong callus and the bone was united. 100% in all the cases. There is no chance of the non-union there. Another technique which we have developed there, because we get a lot of compound fracture. So what happens when we apply the compound fracture, we apply the frame, but we don't care that the bones should be anatomically reduced. Otherwise, I've gone the external fixation, lot of fixation there, the fixator has been applied. But nobody has taken care of the anatomical reduction. So temporary plate was applied here in the compound fracture. And after that, you can see here, and after that, when the frame was applied, this plate was removed there. So this is a temporary plate. The advantage at the bone, we had the single bone there. So it is better to apply the frame. Otherwise, I've seen in many years, frame was applied, but anatomical reduction was not achieved. So that what happens, 50 to 60 cases has gone into non-union. So it is 100%, I'm telling you, as soon as you get the compound fracture, you apply a temporary plate, and after that you make a single piece, close the wound, and when the frame is applied, remove the plate. You can see it was a segmental fracture there. So we have applied the frame, and after that, the bone is united. Another case is genovirus, very severe genovirus. So normally one do that TKR. For 20 years, we are following this case, and all the deformities were corrected. And you can see that deformities, it's a 20 years follow-up. So sometimes you say Ilizarov is a magic. So you don't need TKR. Pre-operative and post-operative picture is there. Mostly you get the genovalgus, knee deformities. So very, very severe genovalgus. So what we happened, we have applied the frame and both the side together, and you can see the beautifully the not beautifully all the deformities has been corrected, pre-operative and post-operative. It's a polio case. She was walking with the stick there. So we are working on the ground reaction and the ground reaction and here tension coming there. If you make by any means straight, so what we have done, we applied the frame and we have the lengthening also. We can show they can lift the bone. You can see that beautifully. We have done the 3 centimeter of the lengthening and recurvatum osteotomy was performed. Beautifully, this girl, she left the stick and walking normal link, pre-operative and post-operative. The main important is the pelvic support osteotomy. This was a girl, 18 years. There were no option. You cannot do a THR. She has got the septic arthritis in her childhood. So what we have done, we applied the frame here. You can see the pelvic osteotomy here. Here we have done the lengthening. This is following, we are following this girl for 20 years. You can see how beautifully all the limb has been aligned. And this is the final picture of the movie. We are showing you the movie here. You see the movie, how beautifully now she is married. Not a single inch defect is there. This is follow-up after the 20 years of this girl. So pelvic support, if it is planned with the mathematical calculations, I can assure you don't need the THR there. Beautifully, the deformity is corrected. Next. Okay. Now, upper limb, main problem in the cubitus varus. We are going to write a book on this because cubitus varus, lot of surgery has been performed, but none technique is 100%. So what we do percutaneous osteotomy. Very thin, 2 rings are given, 2 wires, 1 screw, and 2 screws and 1 wire. And we do percutaneous osteotomy here. So all the deformities are percutaneous osteotomy are corrected there. You can see that beautifully the deformities has been corrected. The advantage is this is whole thing is percutaneous. We do not open normally the modified French osteotomy and other things there. So a lot of complication takes place. So Ilizarov technique, we have developed it. And I tell you, 100% correction and there is no complication is there. Pre-operative and post-operative photograph, we achieve 100% correction. This is another very, very interesting, which I have learned for the KURGAN. You must be having a lot of patients surviving the prolapse intervertebral disc there. So what we have developed, for example, here the space is less here. Here you can see that. What we have done, this is the, I've learned from KURGAN. We applied the frame as soon as, because in PIVD, they interrupted of the nerve by disc. So what we thought, why to not to give the distraction? It will increase the circulation. Second thing, whatever interruption of the nerve is there, that is corrected. So a lot of cases we are doing PIVD who are going to support the surgery. We can save these patients from this wonderful technique. Here apply the frame there. We can do a scoliosis and POTS spine, lot of things can be corrected, but spine Ilizarov fixator. And it was pre-operative final. You can see the space has increased here. So the patient is okay. There is no nerve interruption. I assure you, if we do this surgery, lot of thousands and thousands patients, young patients who are operated for this, you can save that by this technique. You can see that how much big space is here, pre-operative and post-operative. So requisition level 1 basic surgery for every orthopedic Ilizarov is armamentarium of trauma surgeon, or bulk of cases that trauma and movement fracture are segmented part of it. We didn't need to be an Ilizarov surgeon. Learn just basic Ilizarov for open fractures. Apply Ilizarov instead of temporary fixator. Avoid multiple surgeries. Take home message, don't wait for the complication to happen and expect Ilizarov to be magic. Do Ilizarov in the first place when things are still simple. Level 2, advanced Ilizarov for interested in Ilizarov. Ilizarov good option in metaphyseal fracture with severe comminution and swelling. Common deformity, club foot, equinus foot, and the cubitus varus. Level 3 cases for master's cases for fascinated about Ilizarov in gold standard limb lengthening, bone defects, deformity correction. Thank you very much.
Thank you, sir. Thanks a lot for such a elaborative talk, starting from foot to toe. So, without wasting time, sir, John sir is waiting to leave, so I'll be requesting him for his talk. So, next we have our next faculty is Dr. John Mukhopadhaya, sir. He has case discussions today. He's Director and Head of Department of Orthopaedics and Traumatology, Paras HMRI Hospital, Patna, Chairman of Orthopedic Research and Education Foundation, India, that is OREF. He's member of Regional Education Training Team AO Trauma Asia Pacific. He's member AO Trauma Upper Extremity Global Expert Committee, faculty at various national and international courses and meetings, multiple publications in peer-reviewed journals, including papers on Ilizarov bone transport and his other textbook chapters and club for digital humerus fractures. So now I invite John sir for his case presentations. John sir, please.
Thank you very much, Shamsul. I'm going to just share my screen and get started. I'm going to be fairly quick as I realize we are running a bit late. And this is basically a challenging trauma case which we dealt with. And I may have presented it before, but we've got a longer follow-up on him now. So this was really a 7-year-old child who was in a bike with his grandfather and had this accident where the truck ran over the bicycle. And the gentleman you're seeing there is his grandfather, who unfortunately did not survive the accident. And this child was actually stuck under the wheels of the truck. So you can see his limb kind of sticking out here. And he's stuck under the wheel, and he was finally dragged out somehow and taken to the hospital. And that was the condition his limbs were in. Surprisingly, he had no other injuries to his upper torso. He had this degloving sort of injury to his left tibia. And you can see the injury to his right side. His ankle was dislocated. So he was taken to the local hospital where they did the initial resuscitation. And then a couple of days later, this was the X-ray that he came with. So you see the X-rays don't look very bad. The soft tissue injuries are a lot worse than the X-rays look. And when they did the surgery there, they found that there was a problem with the ankle as well, which was very unstable. And so they put on an external fixator, and they also put a wire through the ankle to stabilize the ankle. So when he came to us 4 days after the injury, he had this external fixator on. You can see the complete degloving of the skin, both of the right lower limb, which extended well above the knee, and on the left side where there was no fracture. And there was infection, which was there in the middle segment where the wires had been put in. And this was the X-rays that he came in, as well as the ankle where the KY had been put in through both the joint as well as into the fibula. So our first thing, aim here was to get rid of all the infected tissue. So we did a thorough debridement, and then we put on an Ilizarov fixator. We had to excise a segment of bone there. We had to put the fixator spanning the ankle because the ankle was unstable. And this was followed by the plastic surgeons doing split graft of the entire area, where they had to take skin from his opposite thigh as well as his buttocks and his back to get adequate skin cover. But all split thickness skin, there was no flaps done at this stage. So then we had to decide how to deal with the gap. And because of all the skin being adherent to the tibia, we decided to do a fibular transport where we put in wires, olive wires into the fibula, and did our corticotomies. As you can see here, the olive wires are here. The corticotomy was above and below these wires. And then we transported the segment of the fibula across to the medial side from posterolateral to anteromedial till it was docked under the tibia, and then we could compress it. This actually went on to heal quite well, and at some stage we were able to take out the ring in the upper tibia as well as the ring across the ankle, because the ankle had stabilized by then, and this is what it looked like. And then this is all split graft on this area. split graft through this over the knee and across this entire tibial area. And the graft was taken from both his thighs and his back. So now he could walk on this fairly well, and then we took it out and put him in a PTP cast, which he was walking on, and gradually the regenerate or the fibular graft consolidated, and he had a solid healing of his tibia where he was able to walk without support. You can see by now his ankle has fused. The growth plate in the upper area is still okay. And then over a period of the next year and a half, he started developing this deformity in his lower tibia. So he's going into valgus and a bit of recurvatum. So here we decided to do a supramalleolar osteotomy, again using the Ilizarov to correct the deformity by gradually distracting it anterolaterally to get the correction that we needed. And we were able to get the limb corrected. And this is him at a year later, walking quite well with this limbs quite straight and almost equal in length. However, again, over a period of the next year and a half, you can see he's again developing the deformity, but he's walking reasonably well. He's got a reasonable range of motion in his knee joint. He can flex it to almost 90 degrees. He's walking quite well. He's now 15 years old, but a strapping young lad, and he's able to ride a bicycle. He's dancing, and we actually had videos of all that, but we're not going to show that now. Now, the aim is that we'll do one final correction of the deformity closer to skeletal maturity so that he cannot recur with the deformity. So I think that is basically the case. The take-home messages are that I think trauma management can be complex, and the Ilizarov fixator is really a useful technique with some of these difficult problems. You need to watch out for complications. Remember, you can get progressive deformities in children, and you need to watch out for these because with growth, you can have affection of the growth plate or all sorts of problems which can occur along the time. So you have to plan your treatment very carefully and also counsel your patients adequately and communicate. I think this is, again, I think it was mentioned by Professor Novikov in his sort of talk earlier about Ilizarov and the kind of communication he did with his patients as well as the physiotherapy, etc. I think this is really important that you communicate adequately with your patients, their parents, so that when they have to do the follow-up surgery for the deformities, etc., they are aware of this problem occurring and they're not unhappy when you have explained that to them clearly right at the outset of treatment. Thank you very much. I'll stop there because I know we are running very late. I'll stop sharing. And if there are any questions or any comments, I would be happy to take them.
Yeah. Thank you, sir, for your excellent case. The initial picture will be a nightmare to any orthopedic surgeon if he comes in the emergency, but the final result is beyond excellent. And this also is one of the perfect examples that to have a Ilizarov as an armamentarium with us, so we can play with Ilizarov where it is needed, and we can achieve excellent results. Thank you, sir.
Thank you very much. I'm sorry, I'll have to leave because I'm at another meeting in Kolkata and they're waiting for me for dinner. So thank you very much. Really enjoyed this, and hopefully we'll meet again. Thank you very much. Okay, bye.
Thank you, sir.
Thanks, sir. So,
do we have question from panel? Yes, sir.
Yeah, Shamsul, can you unmute Professor Novikov? I think he's muted. Can you unmute all the faculties? Yeah. So, Professor Novikov, I have one more query. Can you elaborate how many different departments you have in your Ilizarov center, which are focused on one specialities?
This moment in our department we have 22 surgical department and one rehabilitation department, 3 trauma department and one closed fracture, one open fracture, and one department when doctor use traditional technique, plate, nail, and not use Ilizarov frame. We have in our center 3 spine department when work neurosurgeon, only neurosurgeon. 1 department for children, and 2 department for adult. We have 3 department for replacement of joints, hip joint, knee joint, ankle joint, humerus, and we have neuroorthopedy where we have only patient with CP palsy, and we have infection clinic where 3 department, hand department and department for defects. I am a single surgeon, and my patient stay in different department, maybe 5 or 6 different department. And when doctor come, before visit, contact with our cathedra, with our international department, and if a patient has, not patient, sorry, when doctor have interest, for example, for trauma, our staff will prepare some surgeries from some doctor who will support this doctor when foreign doctor or Russian doctor come for faculty. And from Epocha de Ilizarov, we have some specialization. For example, we have hip joint department for baby, and their doctor operate only hip joint, nothing more. If hand department, this is, you understand, only patient with a problem of hand. And just now, young doctor use so many different techniques, technique from all of the world. And for me, I'm a little bit sad because only few doctor, young doctor, maybe 1 from 20, from 30, follow our technique. The young doctor no one spend time for result. Last presentation, doctor show perfect. You're absolutely right, Rajat. Perfect result. But how many months doctor spent only for 1 patient? A young doctor not ready for spend time for 1 result. And just now coming time not so good for young doctor. This is my feeling, because Western philosophy, money is honey, next, and all of technique very quickly need get result. Ilizarov methods not for all of doctor. Ilizarov methods for doctor who can tolerate and who can spend time. And just now, young doctor need to understand if they will go, he will happy, absolutely happy, but our patient need time. So many beautiful results we can get, like pregnancy, only after so many months. And when this baby will born, result, absolutely right, perfect. And when young doctor will start touch Ilizarov technique, how many traumatologists or orthopedics in India? I think thousands, yeah?
Yes.
Maybe 5, maybe more. No, I think more. And all of this doctor has big competition between all of, because all of doctor need know all of technique. But doctor who start use Ilizarov technique, they haven't competition. Why? Because so many doctor no one spend time, and young doctor who will follow life with Ilizarov technique will all life with patient. I invite again, please come in our center. I will support, I will help.
Thank you, sir. Shamsul, can you unmute everyone? So if anybody has to ask any question.
Anybody can unmute. Dr. Yunus has a question, I think.
Yes. My question is to Dr. RA Agrawal. Hello, am I audible?
Yeah.
Sir, of all the cases, the one which intrigued me the most was the spine one.
Yeah.
So, enlighten us, what exactly are you doing, sir? In disc prolapse, what do you do? In kyphoscoliosis, what do you do? From the X-ray that you have posted, I see that you have put 2 pedicle screws in adjacent disc in a short segment frame, and you are just distracting in a trapezoidal fashion or in just elongating it.
Yeah, actually, when we are going to do this technique, you need 2 C-arms because the pedicle should not go to the spinal nerves and other things.
Exactly.
So before starting, we are having the 2 C-arms. About 15 years back, I was not knowing how to use the 2 C-arms. Anyhow, when I was sitting in the airport, and I planned our mind how to do the C-arm. So second thing is we are giving the distraction elongation so that the space is increased gradually, and as soon as patient will say that, oh doctor, I'm getting the relief of the pain. So with normal distance of the disc intervertebral space, we do 4 to 5 millimeter more distraction, so that in future, minimum 5 to 6 millimeter, you can say, so that in future, there should be no recurrence of the deformity. But when we are doing that, so we have to do the vigorous exercises there. That is most important there.
Yes, sir. I understood that the pedicles pedicle screw has to be introduced without pedicle breach. That is understood. But what I'm bothered is the disc prolapse, the basic pathophysiology is an annular tear and the nucleus comes out. So by distracting, we are creating a vacuum in the disc and letting the annulus suck the nucleus, expecting the nucleus to be sucked back. Is that our Okay. And in kyphoscoliosis, generally our spinal surgeon colleagues, they do all the pedicle screw assisted correction. Their correction is limited because all the correction they have to do is on the table acutely. But so since if it can be done by Ilizarov, it can be done gradually without the risk of neurological deficit.
Yeah, actually we were using the kyphoscoliosis, but the number one is a very tedious job. So our aim is that we align the bone, and after that, whatever you can do, that the plating or then rod or other things. It's a very, very wonderful technique is spondylolisthesis. What we do, we distract it, and the anterior fragment we want to anatomical rejection, and after that we do pedicle screw fixation.
Okay.
So it's a wonderful technique, but scoliosis, it needs a lot of time and lot of difficulty. So we are not.
I understand. You are using the regular shank screw that we use in femur, or are you using HA coated? Or
Pardon?
Are you using the regular shank screws that you use in femur, or are you using some HA coated pins?
Femur is the lower end only one wire, and in the compound fracture, other things we are using the another wire, because the problem is that initially if we are giving the load compression, our sense is that in all the fracture unite when the wires become like bow. So we are using less screws, less wires and screws, but below the fracture line and above the fracture line, one has used olive wires so that we could what I felt that why was the cases I got non-union, because then I realized until and unless you don't give the compression, till the wires become the bowing
Bowing
the
up.
wires. Yeah, then you will not get any cases of non-moving.
Thank you.
I have
Dr.
one
Neeraj,
question.
Sir,
Dr. Hoda, I have one question for Professor Rajat. Dear Rajat, with lengthening of any long bones, we understand when we can remove of frame, when we have good callus, good consolidation with spine patient. How you understand when coming time for remove of device? How many days, weeks, months you need fixation
What we do in cases
of the final position after destruction when patient feel pain relief, and how many days, which time for final result, excellent result, and how you understand?
Yeah,
when
actually,
when time coming.
yes. So actually, the reduction part is very less because in spine, even millimeters matters a lot. So in cases of disc prolapse, as we distract few millimeters, there we get a typical finding that the patient gets relieved of the pain, especially the radiating pain. And usually we then send after distracting a little more, let's say 4 to 5 millimeters, we send the patient for 6 to 8 weeks to home. So at least 2 months after the reduction, 8 to 10 weeks, we keep the frame on and we ask them to go at home and do all the household activities and walking and all. And after that only we remove the frame. Yeah, that's it.
Thank you.
Yeah.
Dr. Bera has a question, I think.
yes, Agrawal sir, thank you for
Yes.
the nice presentation. Just one thing, the stage 4 osteoarthritis, bilateral knee, result is really good, but two things. One is, still do you practice it in such advanced stage? Number one, if number one. Number two, will you like to do the same osteotomy at same level or a bit higher nowadays?
Okay, sir. Usually, as usual, if the patient can afford the TKR, then we don't know the osteoarthritis. But if can't afford, or is very thing, sir, I need my joint. So the level of the osteoarthritis will be below the tibial tuberosity, because after that, because there is a ring is there, so we do below the tibial tuberosity and 4 to 5 degree more of the correction of the whatever. For example, if the deformity is 10 degree, so we will do the valgus up to 14 degree. That is our main.
Thank you.
When disconnect.
Thank you.
Okay. This case we are following for 20 years. Now we have
Right.
done that.
Right.
Yeah,
Excellent.
Well, sir, there was a question for John, sir, from YouTube. John, sir, since it was from Dr. Nitin Raja. Why deformity was recurrent? Anybody can answer.
So let's ask Professor Novikov what's his, you unmute Professor Novikov. Yeah, so let's ask Professor Novikov what's his experience. You repeat the question to Dr. Novikov.
Sir, in John sir's case, there's a question from a participant from YouTube. He's asking that why the deformity was recurrent.
I think, sir, yes, Novikov, sir, yes.
Markov, sir.
Hoda, sorry, I a little bit not understand general point of your question.
Post-traumatic Ilizarov and the deformity in the tibia, the lower tibia, there was a deformity. When the tibialization of fibula was done. So the delegate was asking why the deformity was recurrent. There's deformity in the lower tibia.
For me, I think we don't get excellent access. And when we have any deformity, upper part or lower part, small deformity, more worse for extremities than big shortening. And this is, I think, question number one. When we start corrections, we need finished and find excellent access for all of part of extremities. And on the end, I know saw this patient all legs, which kind of angles between femur and tibia. And usually I am agree with Dr. Kumar, this is baby. And sometimes grow line give this reaction, and we have deformity. And usually next stage we use this deformity for increase of lengthening. And usually just now this is patient not post-trauma, this is orthopedic case. And when baby go through trauma to orthopedics position, we need many time touch, impossible to do one surgery for all of life. And if we have some deformity correct, then after a few years we can support this patient again. Usually after trauma, this is doctor show severe trauma, very difficult trauma, but any trauma give reaction with some deformities, and not big problem, correct deformity and forgot. If I understand your questions.
Right, sir. Thank you, sir. Do you have any questions from the panel? We have eminent international faculty. We have Omar sir, Omar Barawi sir, Asharif sir, Munir, Amar Swami, Shibu sir.
Shamsul, are there any more questions?
So we don't have any more questions, sir.
So then let's finish this webinar. And I would like to thank you again, our esteemed faculty who spared their precious time, and especially to Professor Novikov, who gave us insight about our origin, because it was so fascinating to see, especially the physiotherapy, the dedication, and we all are motivated to do better and better in Ilizarov surgery. Thank you all. Thank you, Professor Agrawal, and thank you, Dr. Mukhopadhyay, for sparing your time and having a great lecture. And I think all of the young surgeons will be benefited a lot. Thank you all.
Thank you. Thank you very much.
Thank you, sir. So we invite all our participants for our next tentative webinar on 5th of May. We have Professor JAYANT Sharma from UK Hull University. He has a talk on mechanical stability in bone healing and Islamic pathology. The other faculty will be added. With this, I just stop this.
ये वाला चार्जर में लाया हूँ ना।
Webinar.